Welcome to the Global Tech Leaders Podcast, where we help business leaders and individual contributors with actionable insights to hit their number and figure out the nuances of truly operating a business globally today, squeezing the essence of the lessons learned from the planet's top tech leaders. This is your guide to joining the fast track to global market scaling.
Today, we are joined by Ryan Grant of Vori Health. Vori Health is an all-inclusive medical and health provider practicing holistic integrated approach, starting with musculoskeletal care. It offers full-service physical medicine and rehabilitation care, physical therapy, prescriptions, imaging, and lab ordering, health coaching, nutritional guidance, community support, and premium instructional content. The team consists of carefully selected board members across physicians, licensed healthcare providers, provides health services that are accessible at the click of a button from the comfort and convenience, privacy of a patient's home. So welcome to today's show, Ryan.
Thanks for having me.
I tell you what, I was excited to have you on the call today for our show because we talk an awful lot about getting the next notch in your career ladder and making sure, you know, you're constantly upgrading your skills. You know, we live in this very, very active, bustling society today, but I really wanted to get stuck into, you know, first of all, we'll go through your own career, but, you know, also about what brought you to found the company. And you've received $45 million in funding in May, as I understand. Really keen to understand, you know, where that's going to be made use of and why you're so passionate about that. But maybe just take us through your own kind of experience thus far and what brought you to today, if you would.
Yeah, no problem. Yeah, I grew up in the States, been in the entrepreneurial world since I was a kid, started my first company in my preteen years, got into medical device development, was always fascinated by surgery, medicine, and a healthy disrespect for the status quo of just because this is the way we always do things doesn't make any sense. And prior to Vori Health, founded another company called Nomad Health, which is in the staffing space in the United States that just closed a Series D and growing. But of all the things I've done, this excites me enough to actually widen my clinical practice down to do this full time. Clinically background, neurosurgeon by training, was at Yale University for a while, and then got recruited to Geisinger Medical Center. Geisinger Medical Center is well known in the States, but not as well known internationally, but has a large innovation arm. For example, Google took our CEO to run Google Health, and they also took our chief information officer. So Geisinger is decently innovative in the healthcare system. And why start this type of work and starting in the musculoskeletal sector? Well, trained as a spine surgeon, practiced as a spine surgeon. Musculoskeletal, which is back, neck, hip, knee, shoulder pain and dysfunction, is the #1 cause of global disability. Number 2 is mental health. And there is a high proportion of care that is just unnecessary. So in the surgical arm, let's take spine, back and neck, at least 25%, there's some estimates up into the 50% range of surgeries are not indicated or unnecessary. So as we sit here today at this time, think about all the people on the operating room table who are currently having spine surgery. At least 1 in 4 should not be there. Estimates in the United States are 1 in 2 in some literature. That's relatively disturbing.
Wow.
If you're going to be taking care of people like your mom, dad, brother, sister, spouse, we can't be cutting people open unnecessarily. That's just not fair to them. And it's not that the medical community is bad people. Their business models have been set up since the Great War, which is really most hospital systems across the planet still survive on surgical revenue. And what you see during COVID, when elective surgery goes on pause, a lot of the hospital systems struggle, go bankrupt, or beg the governments for money because elective surgery is on pause. And the analogy is police officer. If a police officer is told they need to have 400 tickets a month to keep their job, but there's only 200 tickets available to give out, they're going to have 400 tickets.
Wow.
And so it's just the incentives are misaligned.
Okay, so I want to get into this a little bit more. So you've raised some really interesting points there, and I've read Dr. Joe Dispenza's book, and he talks about his accident in cycling and how he was positioned with surgery around this, and he refused and rehabilitated himself, and talks about mindfulness, and we can get into that. But I'm supposing there's going to be a huge dramatic impact because particularly on back and mental health, right? And we can take those in order. If we look at back in particular, and I know from literature myself that it's the number one reason people miss work is back pain. And I've suffered from it myself, having played rugby, albeit at a very amateur level in my career. So I suppose what's interesting is what's the impact specifically on the people reporting back pain because they're spending more time sat in a chair because they're not commuting to work during COVID, etc. Work from home has changed dramatically. I mean, for example, here in Ireland, the government have introduced a new law that you have the right to ask your employer to work from home, and they have to give you a good reason to say no. So for me, that says, oh, no commute. But what are the other health impacts of COVID and this shift to work from home, do you feel today?
Well, it depends on what job you used to have, because most jobs still across the planet are relatively sedentary, where you're sitting at a desk. So people who were not used to that, by being less active, are more prone to pain. Some people like working from home, but some people have, given that their social interactions have gone down, there's been a high increase of depression and mental health dysfunction across the planet. Mental health still tends to be relatively stigmatized around the world. But a lot of people, sometimes at least 1 in 4, sometimes more people, are actively depressed. And so it's not uncommon. People just don't like to talk about it. And then just the ergonomics of people leaning over on their desk. And in this day and age, everybody's like looking down at their cell phone. There is some early evidence that by being in some of these awkward positions all the time, that you can increase pain and dysfunction, no different than when you sleep in your bed and sleep on your neck the wrong way, that you wake up and your neck is really stiff and really hurts. And the only way to get through that is to move through it. Those types of positionings can certainly increase pain. And so in terms of your question about what COVID has done, it certainly has increased depression, mostly from social isolation, it seems, where people just are not interacting with friends and family as much as they used to, or going out. So they're just lonely and sad. And then on the ergonomic side is people reporting increases amounts of back and neck pain just because of the way they're sitting, or less active than they might have been before.
Okay. So that's interesting. And I do want to get to mental health. What's your thinking in relation to the prevalence of mental health, both societal and environmental? So what I mean by that is societal is there's always going to be a percentage of that exists. And you might argue that the way that we are structured in our environment today has led to an increase in depression, etc., as a kind of a catalyst and environmental factor. And the kind of willingness of doctors to, like, there's a necessity because some people's biochemistry is off, and I get that, and there's a need to regulate that, versus the kind of the prescription of opioids today. And I know that's a big topic, etc. But what do you think that balance is from a medical perspective?
Yeah, it's a good question. Obviously, we have data on the amount of people who meet strict diagnostic criteria for depression, but you would make the assumption that a lot more people are out there who have it, who either don't ever present to medical care or it's just not caught. So I don't really think we know the real incidence. I bet it's a lot higher than we think it is. In terms of your question about society, there's all sorts of people who have hypothesized about social media or Facebook or Instagram actually driving increased rates of depression and anxiety. Why? It's sort of the FOMO concept, the fear of missing out.
Mm-hmm.
Of people don't post their bad things on Facebook usually, or Instagram or social media. They post the things that are fun in their life. So they post their birthdays, they post their vacations, they post their graduations, they post all of these what are usually happy moments. And so as you go through through Facebook and Instagram, and you're looking through people, all the happy moments that quote others are having, and you're having a down day. For some people, that just makes it worse. Now, what's missing is on most of these social media platforms is people don't share their terrible days, or I had a terrible day at work, or I'm going through a divorce, or I'm going through this, or I lost my job. People don't share those types of things usually on social media. So it's a very biased view of what people are seeing, but there have been, there's not like a randomized trial that I'm aware of, but there certainly have been several reports and hypotheses that social media might actually be increasing levels of depression because people are only seeing the happy times in people's lives, which is not a true reality.
Yeah, it's funny because somebody once said to me, Facebook is what you want the world to think of you. And the reason that Facebook bought Instagram is because that'll give them insight into what that person really thinks of the world, right? So it's kind of like what I would see as below the line, below that kind of societal exposure. But I think that's completely right. We were chatting just briefly before we got on today's show around I was listening to Joe Rogan recently, and he had a guest on, Jamie Lindsay, I believe his name is, and he was talking about the levels of people's brains marinating in serotonin today because of this instant gratification culture. And I'm not immune to it myself. What trends do you see there, and what worries you about that sort of in society today? Particularly, like, I'm 40 years of age now, but my kids are coming to the age where they're going to want mobile phones, cell phones in the next couple of years. What are you seeing, and what concerns you there?
Well, it's part of the society. There's good to have instant gratification, or I would say instant access to information, but people do have trouble disconnecting. Like, even when you go on vacation, you see people have their cell phones, their smartphones, like on the beach with them, or on the pool. Like, it's always connected to the outside world and so people really aren't disconnecting, even when they're on vacation. And there's other literature that it's neural networks, so you get sensitized to things. So if you're continuously having the same stimulus over and over and over, no different than a drug, it takes a higher amount of stimulus over time to give you the same gratification. And so think about people who become alcoholics. It takes a higher amount of alcohol to actually get the buzz they're looking for. Smoking, illicit drugs, and not to say that this is directly comparison, but the instant gratification is still neurochemicals in the brain, serotonin and dopamine, etc., norepinephrine, designed to give you that good feeling. And if you're always able to get instant gratification, there are some documentation out there that are we, by doing that, sensitizing ourselves to this, making us actually become less happy because it takes a higher stimulus to actually become gratified now.
Yeah, I can see that makes complete logical sense. So I want to get into how organizations are or should be addressing that. I want to roll back to what you mentioned earlier around starting, being an entrepreneur in your teens, which I love. I was always big into the, getting a paper route and, doing odd jobs, sweeping driveways, cutting grass, whatever it took. I started selling posters out of my lockers when I was in high school or secondary school, as we call it. So, I can totally relate to that. And then you went down the MD route, and that obviously married a scientific discipline with an entrepreneurial spirit. So you mentioned there about shaping these up and never being happy with the status quo of how things have always been done, which is very Schumpeterian sort of approach, which I absolutely live for. And tell me why you're shaking things up, what gap you saw, and where you guys are playing, and why you're so excited for the future, if you will.
Yeah, in terms of Vori and why which means virtue in some languages, or destiny, and why we started this was going back to the musculoskeletal high rates of unnecessary surgery across the planet. On the evidence-based medicine side, meaning the guidelines, the scientific evidence that we have of what works the best in 2021, at least 80% of the time is not followed across the planet. So the planet's very good at doing really high cost, low value care on every country we have data on, particularly in the musculoskeletal sector. And there's a variety of reasons of why that is, but there's lots of misconceptions out there that, for example, start with imaging, so MRI or X-ray. The public at large is under the conception that it will tell you exactly what's going on with your back for pain. That's actually heavily false. And the reason for that, there's a variety of things. It's one thing if you're in a car accident and you need an image, you're looking for a broken bone. But if you have back pain for 3, 4, 5 days, the chance that an image actually explains the cause of your back pain is under 20%. It's a very low correlation. Now, if you have back and leg pain, that correlation can be in the 90%. It's a much better. But the analogy would be if we took a picture of your house right now or your kitchen floor, say your wood floor, you have a wood floor in your kitchen, and I show you a picture of the floor and ask you, is it squeaking? Can you tell from the picture? It's a ridiculous question. You're like, I have no idea. Right. But static medical images are the same. And so it's like, well, is this patient symptomatic? You have no idea. And what the other concept really that people don't seem to understand is they expect their imaging to be pristine. And so if you have one gray hair on your body, one wrinkle, we're finding spinal arthritis, knee arthritis to a degree. The best way to think about it is the arthritis of your face is wrinkles. The arthritis of your hair is gray hair. That's normal. People don't get worried about, oh my God, I have wrinkles. They might not like that because of the way they look, but they don't get worried about that. And so for the most part, if you're over 30 years old, if we got an MRI of your back, we're finding disc bulges, we're finding stenosis to a degree, which means crowding. Why? It's the same reason that you get wrinkles and gray hair. You're just aging. Doesn't mean you're symptomatic. And so people are under the, people think, or they have this notion in their head, sometimes clinicians too, that the image should be perfect. It's actually, if the image is perfect, that's actually abnormal. Just like as someone who's 50, if they have no wrinkles and no gray hair and they've had no work done, that's abnormal. Then you're like, wow, you have really amazing genes. That's really, really rare. And the same analogy would be if you invite a contractor to your house today and asked him or her to describe everything that's not perfect in your kitchen, you're going to get a list of, well, the floor's off 2 degrees, you didn't paint here perfectly, the molding's coming up a bit, there's a small crack here, there's a scratch on the fridge, and they're going to make a list of all the things that aren't perfect. But they're not going to, and it's just going to be a long list. That's all the radiologist is doing. They're just making a list of everything that's not perfect. And so people get obsessed about, oh my God, I have an L345 disc. You're like, well, the real question is what are the patient's symptoms? Because you can fill an auditorium full of people who have all sorts of spinal findings and are minimally symptomatic. And so it's really about symptoms. And the medical community at large tends to push people based on an imaging finding, because we're not dealing with cancer here, where if you see cancer, you should recommend to the patient usually to take it out. When it's just pain, not to minimize how much pain can bother somebody, we don't have great evidence that if you choose to live with it, that you incur any permanent damage. And so when it comes to back pain, neck pain, leg pain, arm pain, etc., is that the person's neurologically fine, meaning they have full strength. It's really the patient's choice. What are you willing to live with? Now, most people will get better through a non-operative platform program, usually about 85%. About 15% of people won't quite get where they want to go. And those next set of people, you would then get an image to see if there's anything you could potentially do that's invasive, surgery or some other modalities to see that you could potentially help them in that way. But to take a step back, the people who don't get where they want to go, it needs to be a conversation with the individual. Well, you didn't quite get where you wanted to go, Ross. the next step would be to obtain an image to look for surgical targets to see if there's something more invasive we can do to help you. What are your thoughts on that? My experience, about 20% of people will say, well, I'm not exactly where I want to be, but I'm not bad enough to have to want surgery.
Sure.
I don't think you should image those people. And it's just a waste of their time. It's a waste of dollars. And you don't need the word that said that my doctor says I need to have surgery when it's just pain actually makes no sense. It's like the patient's the person who's living with the pain. It's actually their decision. It's not the medical community's when it comes down to normal pain. If that makes sense.
Yeah, sure. So it can be managed. I mean, there's obviously medication, you can take drugs for that, but also you can do other things, including exercise and rehabilitation, as you mentioned there, to strengthen your core and, you know, your back and such as well. Why do you see corporate environments sitting up, to use a terrible pun, and paying attention of the employees and their employees' wellness today?
Well, one is the right thing to do, but two, I don't want to say it's a bandwagon in terms of people wanting to make sure, but it's a good bandwagon that as others have done it, that they should do it. But no, there's higher rates of burnout. Mental health is more prominent in terms of, at least, is it in terms of people experiencing it. Sort of the work ethics across the planet have been, depending on which country you're in, is how much harder can you work next year so that you can do more work. And in this remote culture is what I think people have come to realize is there's sometimes even less disconnecting, where work and home are just all blended together, where some people are finding that they're working every day. Sure. And which is very different from when they used to go to the office. Now home is the office, and you're quite a few people, including myself, have been bad at this, where you're just always on because now home is the office. And in terms of the wellness side, is pushing people's limits to sort of destigmatize mental health is important. If you do end up into the depression or anxiety, you don't perform as well at work. You don't feel as good. And so it's actually better to help take care of your team, to promote wellness and help keep your team members and treat them like family, to help them do better. They'll actually be more productive. And from a corporate standpoint, when it comes down to finances, it's actually more financially responsible to help take care of your team members' health, because it's actually cheaper to do that. It's better for society. It's more ethically sound than the amount of money you're losing from them not really performing because they don't feel as well.
Yeah, that makes sense. That makes complete sense. You're seeing it all around, and people are more productive. And even since they're working from home, they're more productive. I mean, I remember when smartphones came in fact, the VP of site gave everyone a smartphone when a smartphone 10 years ago was not a thing. It was quite expensive, but he worked out that you get 4 more hours of productivity per week per person. And that's even gone up since then too. But it's shifted, right? So I think that assessment is very much my assessment of what I've seen as well. So let's shift gears and talk about you for a moment. You guys have just acquired $45 million in funding. What's your expansion plan look like, and what excites you about where you're headed?
Yeah, thanks for that. Yeah, so what we're building, given all of these things that we've been talking about on the musculoskeletal side, that's where we're starting. We'll expand into other specialties over time, but starting here is we formed integrated care teams. And so it's a mixture of health coaches plus sports medicine physicians, physical medicine physicians, nurse practitioners, physician assistants, nutritionists, which are registered dietitians, social workers, and the list goes on, of actually putting care teams together so that you can see multiple people in a true care team that's based around you, versus have to have 4 different appointments with 4 different specialists in 4 different buildings. We started heavily virtually because of the rise of virtual care, and then blend all of that with evidence-based medicine. So doing the right thing that follows actually the scientific guidelines. Then also bringing in what's called shared decision-making, which is the patient's at the center of the care. what some of the things that we were just talking to, of what's important to you for your life is going to be different or could be different than your neighbor or your friend. And so what's best for your life in the medical community should really be a guide of here are your options, and really bring the patient's voice to the front. Medicine doesn't do that very well. Medicine tends to be heavily paternalistic in terms of you need an image, sir, you need to see a surgeon. It's heavily telling people what to do versus actually involving them into the care. And then medicine, for lack of a better word, even when it's done well, tends to be boring. It's like going to the airport. You're like, it's a transaction. But to make it more social, and the number one pillars of behavioral change are social, who's your social community, what's your education, et cetera, is to blend all of that with the social community. So you have the option, you don't have to talk with other patients or other people who are in your similar condition, to do care with them if you so choose. And then when you're not working with providers, to have a lot better content, educational content, because when you think about the content that exists in the medical community, the number one content that they will give you, your clinician, physician, nurse, et cetera, is usually nothing. So the number one thing people get is nothing. The next is maybe a YouTube link, or your doctor or clinician scribbles on a napkin or a piece of paper in the office. Oh, here's the words we just talked about, look it up on Google, or something from like 1980. And so the content out there is pretty terrible. And so pushing the levels of engagement. And so we started seeing patients in the United States earlier this year, and we'll expand into several of the other states. We do have a Canadian subsidiary that is a engineering and product hub. We will also look to expand care directly into Canada in time and other countries.
Okay.
We are also looking as early as next year about standing up a subsidiary also in Dublin for engineering and then product, but then also would look to also bring this type of work in terms of patient care to the Irish community. And really the way we think about it is wherever there's human beings, which is every country, there are ways to drive value. And yeah, each country has different cultures and different regulations and some different laws. But at the end of the day, it's still the human condition of most people in their life will have an episode of musculoskeletal dysfunction. It's about 1 in 2 people are affected by it. It is the top cause of global disability. And so there's no reason to not strive to be global over time. And so these funds are designed to do several things, is to expand more across the United States, build up some of our subsidiaries more, get into data analytics, more content, the social community. And then as we get larger, we will look to be, well, which countries are we also going to go to first to do direct care and help those communities as a true partner?
Wonderful. Well, I always like to hear people say they're setting up in Dublin, and that's obviously a great accolade and speaks to our environment, and we can certainly get into that. I'm kind of curious to know, like, our healthcare market is a hybrid market, and over, I want to say 60% of the market has private healthcare versus socialized medicine provided by the state. It's not like the UK where it's, fully NHS, or the Scandinavian countries. It's everything is provided for as such. If you wish, you can go private should you wish to. But how does that play into your model, Ryan?
It's a great question. It's starting in the United States it's one of the more complicated economic systems because it's all over the place. So in the United States, most people get their healthcare on the private market through their employer.
Yep.
There are hundreds and hundreds of insurance companies. Each state is different. So each state has its own insurance regulations and rules and own licensing. And so even though it's under one large country, each of the 50 states operates independently. And so each of those you can think of as a box with different insurances and different insurance types, and nobody talks to each other. Even Medicare, which is the national system in the United States for people over 65, that's offered by the federal government. You have to register for it separately in each of the 50 states. So even though it's a federal system. And so that's the second largest group that people get. So most people don't get private insurance on their own. That's the smallest sector in the States. And so majority of people are getting their insurance through their employer, which is usually a private insurance, through one of our payers on the private market. The next set of group is what we would say is the elderly, but we define that as 65 and older, which is the Medicare population. And then for lower socioeconomic, it's the Medicaid. And so that covers most of the states. Less than 10% of people actually go to exchange and buy their insurance directly. And so given all of these different types of insurances and payers, both fed national, individual, private, self-pay, is we're able to, in this country, work within all of those business models of take dozens of types of insurance, also take the national insurance, allow people to self-pay if they so choose, or if that makes sense to them. And then also start to broker contracts that are more novel, where you can set quality metrics and take what we call risk, where if you're with a payer or an employer, if we drive down unnecessary surgery and unnecessary imaging and unnecessary opiate utilization and a variety of other metrics, which saves you a bunch of money, we should split the savings. As another type of model that can be done, depending on the interest of the payer.
Excellent. Okay, that's very interesting to know. So what's your vision for the future, Ryan? Where do you see this kind of playing out, and why are you so passionate about the change?
Yeah, it's a great question. It's what keeps me motivated and going is if you look at all these folks on the planet, like if they were your mom, dad, brothers, sisters, they should be treated that way. They should get the same care that you would want for your individual family members. People say that, but that doesn't tend to happen. Like a physician, what does he or she really want for their spouse or kids is not always the same thing that actually happens to their patients. And I don't think there should be a difference. It's like the way you would treat your family is the way you should treat your patients 100% of the time. And so rebuilding a system like this from scratch allows us to align the incentives, allows us to put all the care providers that a person needs based around the patient, literally start over and be patient-centric to an extreme, really pull that person into the realm of decision-making, truly treat them like family, redo even how we talk to people. So we don't say things like, you need this. It's like, well, here are your options, Ross.
Yeah.
What do you think about these types of things? And really be a guide versus someone who's just giving you orders all the time of what you should do with your life. Well, that might work for somebody, but that doesn't work for everybody.
Sure.
And rehumanizing medicine, like when you even think about the medical charts that are done across the planet, and this is how it's been set up for a long time, is I was at Yale for a while, and pick your brand name is the way we train our clinicians, physicians, nurses, etc., is to dehumanize everything when you write notes. For example, this is a 48-year-old man who has high blood pressure, diabetes, and high cholesterol. And then they go, and who's here today, versus this is John's a 48-year-old mechanic whose favorite pastime is traveling to the Caribbean. And this is sort of like who's John in a sentence versus this is a bunch of diseases that has an age on it. So we really do across the planet treat people like objects in the medical community, not intentionally. That's how it's been set up for a long time, but it's heavily dehumanized. And if you train all of your medical students and nurses to even write notes that way and then present to each other that way in a medical system, that really does change your thinking pattern, because all day long you're thinking about, well, that's a 48-year-old with hypertension, that's a 48-year-old with this, that's a 72-year-old with COVID. So that's just people are just known as their disease states versus as a human first.
No, I love that. It's like a bartender knowing a customer by their drink of choice. But what you're saying is you want to know their backstory ahead of time. And I was actually going to ask you one final question, but you've kind of usurped me and gone ahead and answered it, which was how do you help a guy like me who has genuine squeamish tendencies around going to the doctor in general, but sounds like humanizing the approach is the way forward, if I'm understanding correctly.
Yeah, it's average person doesn't know if the medicine is good, bad. They don't know if it's evidence-based. You do evidence-based medicine and you follow what we know to the best of our ability if it works, because that's the right thing to do. What people do know is, did you treat them well? And they'll remember how they felt. And so there's people who like their individual clinicians because of their personality or bedside manner. But when you think about the entire ecosystem of the health systems at large, they're not like, wow, I can't wait to go there again. It's so amazing. People don't talk like that. And yeah, we're dealing with all sorts of processes. But when you think about school, like there's lots of parts about college or graduate school that aren't very fun, but the experience tends to be quite a bit better overall than it is in a hospital. And so we're not trying to get this to be like concierge, like a hotel, but there's something to be said about how far can you take it where you deliver amazing healthcare that's centered around an individual, where it's really humanized again, but it doesn't feel like healthcare. So they're getting great healthcare, but it doesn't feel like what they would think about healthcare, if that makes sense.
Love it. Love it. Well, look, I really want to thank you for your appearance on today's show. You've added a ton of value to my understanding of the space and made me feel an awful lot better about going to the doctor going forward. I need to get my COVID jab in the coming few days. So thank you for appearing on the show, and we look forward to having you on again in the future, Ryan, if you're up for it.
Yeah, absolutely. And we look forward to getting together in Dublin at some point.
Fantastic. It's a given. You can bet on it. Take care. Thank you.
You. Yeah.
You've been listening to the Global Tech Leaders Podcast, designed for both established and aspiring career-focused tech rock stars, as well as helping leadership figure out how to speak global in today's multicultural world. For further details, check out sf-talent.com.